Next up is Dr. John Fruehauf. Dr. Fruehauf, again, is another one of our distinguished faculty. He, again, wears many hats, and it's been on both sides of the aisles, in fact, as a associate professor of medicine and director of the development of therapeutics for the Child Cancer Center, but also the chief scientific officer of a company. And so here's Dr. Fruehauf.
We thank Dr. Rosen for organizing this meeting and all the people that are here. And I particularly like Dr. Green's comment on the body count. I think that's so telling, that the reason we change is because somebody gets hurt. 911 and airport security. We take an oath. I remember the white coat ceremony I went through as a medical student, and that was the Hippocratic Oath. Of course, it doesn't say do no harm in the Hippocratic Oath. It's in the Analects. We get confused about that. But if you go and investigate it, you'll find that, in fact, do no harm is not in the Hippocratic Oath. But to protect from harm and suffering is the guideline we follow. That's the principle, to protect from harm and suffering. And I think we're all in this together to do that, but these ethical issues about who are we protecting from harm and suffering, our family, our patients, and of course we're as physicians to put our patients first, but there are conflicts. And there are conflicts in many aspects of research. Next slide, please. So what are the objectives of research, at least in medical oncology, and I think in general, it's to conduct valid research. And we've talked about how we can assess validity. Protecting the participants is very important. What kind of consents were there for people getting these spinal processes put in? Were they told about the potential risks? Are they told about it today? How would we know what the risks are if they're not reported? So disseminating the findings is critical because people have to know, physicians need to know, when they're talking to somebody, what the truth is. They have to go to the library and read the journals to know, when they're putting somebody on a drug, what the risks of that drug are. That's a responsibility, to understand how to protect your participants, and that depends on the findings having been disseminated. That's an issue. Next slide. Next slide, please. So the responsibilities are to follow the policies of professional societies. We are members, as physicians, of societies, and one of the roles of societies is to offer guidelines. And it's sort of like the Pirates of the Caribbean, you know, it's a guideline. But it's something that we should pay attention to, and we do. And that's where transparency has been generated in medical oncology to a large degree, is through the American Society of Clinical Oncology and the principles. We want to contribute to the medical center we're participating in. We want to contribute to our department. And we have a responsibility to our students to provide mentorship about ethical principles and how we make choices. And every physician is going to take a little different approach, and that's the beauty of education for the student, to gather a diversity of approaches and then integrate their own. So teaching students how to think is part of mentorship, but not telling them we have the right answer, but that they can decide the answer themselves through positive mentorship. And we have a personal responsibility for scientific integrity and for family and friends. And this can sometimes be an issue. Scientific integrity versus bringing home the bacon. Next slide, please. So competing interests are relevant, and we have to look in the mirror and we have to ask ourselves, as responsible participants in this process, what are my goals? Just as the ethicist was bringing out, we have to ask ourselves this question. It's not something that is academic. It's something that's personal for each practitioner. What are my goals? Do I have competing interests? Are they overlapping? And how am I going to see myself through this or get through this process in an ethical way? Next slide. So the term conflict of interest in science refers to situations in which financial or personal considerations could compromise or have just the appearance of compromise of the investigator's judgment. Do I want to put this patient on the trial because the company is giving $2,000 per patient to the university? Or do I believe that this is an important study and this patient needs to be put on this trial to help them and to help science evolve? And it's not just the individual patient that we're considering. It's moving science forward, making a bigger contribution. And in fact, that's why patients are heroic, because they'll go on studies even with great risk. And part of it is because they believe they're making a contribution. And that's part of our sort of motivation. So the American Association of Medical Colleges has done a great deal of service to us all by organizing principles and guidelines, because the medical students, the young people learning to be doctors, need to do this in an environment like Ben Franklin said, where there isn't an issue about your being corrupted by money and how much money you have to make and how you're going to do your billing and what your coding is, but what are the principles of patient care? What do we want to bring to the clinic when the patient's sitting across from us? And we have to look in the mirror all the time to understand what our own internal conflicts are. And I think that's the principle. Ethics is personal. It's kind of like religion. Next slide, please. So competing professional or personal interests can make it difficult to fulfill our duties impartially. At least understanding for ourselves our own internal transparency can help us understand our biases and release us a little bit from making decisions without understanding why we're doing it. Secondary interests can undermine our objectivity and our rigorous pursuit of good conduct of research. And if we can't understand our own motivations, we can't protect our patients. So soul searching is what I'm talking about, and the importance of it for each individual physician. That's where the rubber meets the road, not in a guideline on a piece of paper. Next slide, please. So the integrity of research is what's at stake, and each individual researcher is contributing or not to that integrity. One bad apple can spoil the bunch. Public trust and confidence is important. At UC Irvine, we have gone through several different issues related to ethics. Someone's eggs were put in someone else. That was a bad thing. How could that happen? How could someone take person A's egg and put it into person B? What were they thinking? And that act affected UC Irvine's ethical milieu and led to guideline and a TV movie. So we have to think for ourselves and take personal responsibility, but I think the institution has a role to teach people how to do that. I think that the answer is people aren't automatically going to think like this, and we need to provide an opportunity to train people how to do this and why it's important. That's where ethicists come in and their courses. So we want to protect our reputation, but we want to do it for the right reasons, not just because we're here to protect the reputation of the institution, but because we want to protect everybody by doing the right thing. So that's the human subject welfare. So we have an obligation to ourselves and our institution and our families. Next slide. So conflict of interests are really unavoidable. There will always be conflict of interests. Some are stated or implied. Some relate to professional advancement, academic position, salary, and so on. So how do we understand our position in this process to maintain our integrity? Next slide. So severe restrictions on financial benefits to investigators for research products is one way this has been done. And at NIH, where I was a fellow, you could not go out and speak or write a book. You couldn't publish a book because you would make money on your book. So you couldn't write a book because making money is bad, because that's a conflict of interest. You couldn't go and speak on behalf of a company about a drug that was working and important and that people need to know about, because we have to disseminate good information, because that's a conflict of interest. And many people left the NIH to go where it was more remunerative. And they call that the brain drain. So this is a problem too. We have to be cautious in how we approach these issues. Money is not the root of all evil. It's the love of money that's the root of all evil. So this whole issue can be deleterious and block the progress of science if we're not careful in how we disseminate these guidelines and follow them. And we don't want to throw out the baby with the bathwater. Next slide. So pharmaceutical companies, unfortunately today in the world, with the war going on, funding is very, very limited. And if you have an idea and you want to try something new in your patients, the pharmaceutical companies have the drugs and they have the money to do the development. And so we have to go and work with these people. So how do we work with pharma and do it in the right way, where we can look in the mirror and ask the right questions? This is the issue. So there are systems that have been set up. There's a global regulatory monitoring system in place, the ICH and the FDA, which are there to provide appropriate checks and balances. So just because there's money behind the development of a drug and there's a profit motive doesn't mean that that's bad. But we have to have these systems in place to make sure that the data that come out and the way the research is done is appropriate to protect the patient and to protect future generations. Because if more and more people get bad things, future generations are affected adversely. So the good news is, because there have been bad situations with sulfas that were contaminated, and people died, and there was a body count, we have regulatory systems. And the regulatory systems, for the most part, have been working for drugs because that's where the body count started. Devices are coming into this now. They're delayed in the regulatory environment. And I think it's good for the device people to look to the drug environment to see how did that work and try and follow suit where it's good. So there is no data to suggest that patients that go on pharma trials versus cooperative group trials are at greater risk. And in fact, pharmaceutical trials have more controls because the FDA is watching. And if I do a study here at UCI, the FDA is not going to come in and audit my little trial. But they are watching the pharmaceutical company trials carefully. And so the quality of data is so much more complicated. How many sheets I have to fill out? I spent an hour yesterday filling out 30 sheets for a trial for 2 patients to make sure every piece of data was correct. It's incredible. Next slide, please. So is it true that a researcher with a financial interest may interpret the data that's more favorable to the industry? Probably yes. It's an unconscious bias. And that's why there has to be external review. And so in pharmaceutical trials, I could read the CT scan. I could believe that the person's responding and should continue on the study. But there's going to be an outside reviewer for these studies who's going to look to see, was Dr. Fruehauf correct? And that's where there have to be these balances, because no matter how soul-searching we are, we're always going to be subject to unconscious bias. And that's why external review is so important. And that's been set up. So if somebody has a scan of someone's back with a device in it, and I think this looks great, we need to send that x-ray over to Joe, who's completely unrelated on an independent panel. And there were some names that weren't read on that list. There are some people that are unbiased and can't look at these things. Now, one of the big issues is, how is the data reported? To publish a paper today in the Journal of Clinical Oncology, you have to give all your data. The FDA data are looked at independently of the data submitted by the company for a paper. And they pull papers if they think the FDA data doesn't quite match what the drug company's data was in the paper. So it's really stringent. But the downside would be that not all negative trials are reported. And this is where we get into a little bit of trouble. People don't want to publish the negative results. They don't want to say this drug failed. And so a lot of people end up reinventing the wheel, and patients are re-exposed to things they probably could be protected from. But there's no profit usually in reporting negative results. But this is evolving, and people are going to be doing this more and more because we realize how important that is. It's a responsibility. Next slide, please. So patients generally assume that there is this oversight to ensure that the conflict of interest doesn't compromise research. Every consent form, if I give somebody blood and I'm filling out the form to give them blood, I have to tell them I don't have a financial interest in this transfusion. I mean, it's at that level today. You always are addressing this with the patients, and they can feel a sense of trust. And that's really important. And this is built in. And the conflict of interest can vary depending on where you are at the institutional level, but this system is becoming standardized. And I believe the real issue is not so much that the systems aren't there, as the people who are physicians who are so busy doing things every day don't really know what all these systems are and how their participation is supposed to fall out in the process. So education is so critical for understanding on the part of the physicians. What is set up? What's the system? And I think an important part of this is the safety of the patient is related to the disease they have. If you're a healthy 13-year-old and I'm going to put something on your foot that could lead you to be permanently disabled versus you're a 13-year-old with a life-threatening disease and you're going to die in 4 months if something isn't done, those are two different ethical situations. And in cancer research, we're dealing with people that are going to die. And in spite of that, we have all these safeguards. And some people don't even get on trials because we're too careful sometimes. And that's the pediatric population. Next slide. So we have to disclose our financial interests and our relationships. And when I gave a plenary session at ASCO 3 weeks ago to talk about my phase 2 melanoma trial with an oral anti-angiogenesis drug, my second slide was our institution received research funding to support research on that drug. And I'm acknowledging to everybody that I've received funding. And so they can take and interpret the data appropriately. And that's really what we're talking about, transparency. The motives have to be clear. And there's a little card I noticed for me in your folders of the different trials that I participated in. That's full disclosure. That's so important. So we have to really understand how there are commercial interests that could go beyond what we're currently disclosing. And we need to know what's the extent of honesty and openness that's necessary to protect society and to protect ourselves as investigators. Because it's, again, looking in the mirror. When I'm filling that paper out, I'm looking in the mirror and I'm thinking about what's my role. So individuals with whom the participant directly shares income, such as a spouse, if I'm married to somebody who works for a pharma company, that's important for people to know about. It's not just me, it's people that I'm related to. And so that's the extent that this is going to today, which I think is very important. Next slide. So committees exist, but we need to improve the communication and education for investigators. And the guidelines need to evolve over time as events occur. We need to be foresighted. We need to look to the future. IRB oversight of financial interest isn't something currently that's a major and important, but I think when we are going through the IRB process, the IRB committee needs to understand clearly what the components are that are related to the patient, the physicians, so that if you have financial interests, it's clear on the consent form that's comparable to the ASCO guidelines. And I think that UCI has really done a good job, the UC system as a whole, and I don't have any pens today because I'm ready for July 1st where you can't take any pens from the pharmaceutical companies. I think that, next slide. So I think we all have some interest. Thank you.